Our second TED Talk is titled, Something is Wrong, I'm Concerned. This presentation will be done by Marie King. Marie is the Quality Outcomes Coordinator in the Department of Performance Improvement. Marie King is the Outcomes Coordinator in the Department of Performance Improvement. She has been a pediatric nurse for 30 years. She received her BSN at Stevenson University in Townsend, Maryland. Her primary focus in her career has been to ensure and provide a high standard of quality care to children. In 2008, Marie joined Children National in the role as Clinical Coordinator. She was later promoted to the role of Clinical Supervisor. In this role, Marie focused on clinical improvement activities and in 2013 accepted her current position in performance improvement, where she continues to drive quality improvement efforts at Children's National. Since 2013, Marie has worked closely with Dr. Nathan Dean and Maybrit Sten on the Late Rescue Collaborative. Please join me in welcoming Marie King.
Good afternoon, everyone. Thank you, Dr. Mason. I want to thank everyone for inviting me to attend this. This is really exciting to share this information. And as Dr. Mason had pointed out, I'm here to talk about the work that we've been doing around late rescues. So about a year ago now, an internal collaborative was formed to really look at children that had been transferred to an ICU unexpectedly. So we really, from literature, we know that unrecognized clinical deterioration may lead to arrest, and pediatric arrest survival rates are poor. We also know from even our own data that there are changes in patients' conditions hours before the arrest occurs. And even though we have implemented a lot of measures here at Children's, we continue to see unplanned unplanned transfers to the ICUs that qualify as a late rescue. And we really wanted to try to drill down as to what's going on here, what can we do to improve this process. So you might be asking what a late rescue is. The criteria for a late rescue for a patient here is one of the following must occur: it's an unplanned transfer to a higher level of care, the child is intubated, receives intraoperative vasopressors, or has non-invasive ventilation, CPAP or BiPAP. So as we gathered the troops together to form this collaborative team here, we wanted to look at how we can reduce late rescues here at Children's by 30% in a one-year period, and how we can do that, and what we needed to do that. And we thought that in order to do this, we needed to have reliable and accurate PEWS scoring. And PEWS is, as we know, it's a pediatric early warning score for patients. It's appropriate, and we wanted to look at the appropriate use of the escalation algorithm, and really need a robust plan that the nurses can follow and the physicians know when they are asked to come to the bedside to assess, either at photo watcher note or our CAT note or rapid response team. And then we also wanted to evaluate all of our late rescues. So our first project was to develop our key driver diagram using the IHI model. We developed our key driver diagram to see where we wanted to take this work, and we felt that, again, these were our primary drivers that would help improve our work. So in the beginning, we set out, we used one of our medical care units to really figure out what's really going on at the bedside, what's the nurse's workflow, what are some of the challenges, and wow, did we learn a lot. We learned that giving a child a PEWS score was more complex than we ever thought. We had asked the nurses to fill out surveys and just really was asking, you know, when do you assess a child for a Pew score? Do you use a CAP refill every 4 hours? Do you use a CR monitor? Do you not use a CR monitor? With all these questions, and we gathered all this information, looked at it all, and really was like, okay, well, this is really interesting. So we came back a year later. Unfortunately, we did not reduce our late rescues by 30%, but what we did come back with was a more robust key driver diagram, and I have to say, I was never a fan of these key driver diagrams. I couldn't understand them. I hated working with them. Poor Brett, I thought she was going to strangle me at one point, but this, I have to tell you, is our working plan. We pull it out, the collaborative leadership pulls it out, looks at it, figures out where we need to go. It's our roadmap. It has been absolutely fabulous to look at this key driver. And one of the things I wanted to really point out was because through this whole project, what has been instrumental is the feedback and the work that we have done with the nurses at the bedside. The information that we've gathered from them, everything that they've been able to help us, it's been crucial. And so one of the things that we did do was looking at accurate pews. Were we really having accurate pews? Was there a good understanding of that? We had a lot of nurses say, well, you know, of course I don't have it on me, but everyone will look at every time you ask someone, so what was that child's pew score? Everyone will be doing that. And there was a lot of concerns about the card. There were some typos, there was some stuff that just didn't make sense to people. So we knew definitely we had to improve that job aid because people do rely on it, not just nurses, physicians. So when everyone's trying to have a shared mental model, they're all standing together looking at this. And we needed to make sure that all of the elements surrounding a Pew score is incorporated at that time of that assessment. There was a trend to just really look at heart rate and respiratory rate, but we all know that a Pew score is heart rate, respiratory rate, a CAP refill, the color of the patient, the behavior of the patient. And you need to take all those elements together at once to really say, ooh, this is what this patient's doing, and really give yourself a sense of, you know, should I be worried? Am I not worried? If, you know, the score is this, why is that score that? So it just kind of helps to pull everything together for the nurses to really give an adequate Pew score. So we knew that needed to be educated on, and we needed to relook at some of our systems that has been in place that has kind of led that discrepancy there. We also wanted to, and this I think has been a huge win for us for this past year, is we wanted to create an automated calculator for the nurses when they enter into the EMR, their assessment. We really wanted to have a more robust documentation process for them. And then, of course, with that, one of the things that we learned way back when, a year ago, was that there is some delay in documentation of our pews. So needing to really figure out how to work that into the nurse's workflow. There's a lot of barriers to that. We haven't quite figured that one out yet, but what we did figure out, and what we have worked very closely with Cerner, is this more robust Cerner enhancement for pews. It's incorporating all those critical, what I would like to call bundle elements for pews, that a nurse will have to assess when she's actually going in to purposely assess her child for a Pew score. So it's looking at the behavior. So you're looking at behavior, you're looking at heart rate, but along with heart rate, you're looking at that child's skin color, you're looking at that CAP refill, you're looking at respiratory effort. And not only just respiratory, you know, not only your respiratory rate, but your respiratory effort, and what are the oxygen requirements. So it's pulling all these crucial elements together. And the bonus for the nurse is it does all the calculations for them. So that's the bonus. What we hope that will happen is either A, you'll be worried about your patient way before the Pew score, or that, you could come up with a Pew score of 5 and think, ooh, wait a minute, why is this patient a 5? And then further down, it's really then saying, well, what do you need to do about this score? Do you need to notify your charge nurse? It's putting that algorithm in place. Do I need to notify the charge nurse? Do I need to notify the resident? Do I need to call a CAT? Is this just a watcher activation? So it's pulling in all that stuff to help guide how we want to process through this. The second piece that we are rolling out, we're all rolling this out together, and I apologize how it's all kind of up and down. We redid the visual aid tool as well. One of the key things that we changed was really taking out and simplifying the language for the Pew's calculation table, making it ORs instead of and/or, clarifying some of the respiratory stuff. The biggest thing that we did change was on top of the escalation algorithm was, are you or the family concerned? Because that is one thing that we have learned too is, I've had nurses come to me and tell me, I was really concerned about that patient, but I could not score that patient any higher than a 3. And felt uncomfortable about, escalating. And it's like, well, you just need to escalate. If you're concerned about the patient, that's all that matters. If the family's concerned about the child, that's all that matters. So we're really trying to drive that home that outside of the Pew score, if you're concerned about your patient, escalate. And in the meantime, as you assess your patients, you're pulling in all those elements that you are properly giving a good Pew score to that patient. So it is a point of reference for everyone to refer back to. And that's it for me. Any questions? Right? Thank you.